one of the things we will be discussing today, outcome measures and presenting the impact of your work. So one of the sessions that we did a couple of months ago was looking at how to develop allies within your PCN. And one of the things that, that came up out of that is talking about the impact of your work, being able to speak in terms of case studies and data around the impact that you're having with your patients. So if we could go to the next slide, I'll just introduce myself. So for those of you that aren't, that haven't met me before, I'm the Regional Learning Coordinator for social prescribing across London. And the main focus of my role, I sit within the Healthy London Partnership Health Inequalities team, and we work as part of a wider personalised care team, and the focus of my work as an NHS associate is to support link workers and build a bit of across London and build a bit of a community of practice. So we do that in a number of different ways. We have a newsletter which I'm guessing you all receive, and we have drop-in peer supports that happen every other week for those of you that might be interested to join and hear and share some of your challenges with other link workers in other bits of London. But we also host a monthly webinar that has mainly got a focus on peer learning. So understanding what's happening, we'll take a theme, we'll understand what's happening in other bits of London, and maybe discuss some of the challenges around that theme as well. Today's quite an exciting session. If we could go to the next slide, please. Today's quite an exciting session because we have we've got a few we're bringing in some people from outside of the kind of the community of practice of link workers and their managers, and we've got some speakers who will be talking about things that are pertinent to the subject of outcome measures and presenting the impact of your work. So this is a really informal session. These are we noticed there weren't so many people coming along to the ICS level peer support sessions because there is some really good peer support happening out there in your local systems. So this is really kind of an alternative to that, and it really is. It's got lots of the same objectives. We really want you to meet each other, talk to each other in the chat, if you could change your name, so it could be your name and which borough you're working in. It's really useful for link workers to be able to spot link workers in other boroughs, so maybe you can reach out. Feel free to share your contact details if you're chatting with people and you want to connect outside of this session. I'll take the opportunity to remind you that we have a London section on the future NHS collaboration platform. Now, if I think Justina, who I'll introduce in a sec, will be able to share in the chat the recording of that National NHS England, they put on a webinar recently to talk you through how to use the future NHS collaboration platform. But that's another place that you can connect with link workers. We've got a London region, there's loads of resources on there, lots of opportunities to start discussions. And it really, those types of resources they're as useful as the people using them. So the more conversations that happen on there, the more sharing of resources, the more useful that resource is going to be. Today is recorded, and we will be sharing the recording and the slides in both the site to whoever has signed up today, but also in the newsletter. So please feel free to go away and tell your colleagues about this and invite people along to the next one. I think the next one we're going to be doing, we weren't actually planning to do one for August. We were going to have a month off because there's quite a lot of people away, but we've had an offer of somebody that really wants to look at how link workers are working with people with refugee status, asylum seekers and people with refugee status in London. And we've got some really good examples of stuff link workers are doing, and a couple of Public Health England are keen to host a session. So we thought we'd support them in delivering a quite specific session in August, and then hopefully we'll be picking up in September, probably on the theme of ending with either on the theme of working alongside the other additional roles, or possibly ending with clients, so setting boundaries and how to end with clients, because that's another subject that keeps coming up as a need. I want to introduce Justina, who is she was I should let you introduce yourself, but one thing I want to say is that Justina's been working with us since February. She was a link worker in Ealing, and her passion for the development of social prescribing and advocating for its value and the positive impact it can have in patients' lives was really sort of shone in the peer supports that we were doing and some of the extra work that she was sharing with other link workers. And we're really really privileged to have her in the team. She's just recently been offered a job and has accepted to join as part of the Health Learner Partnership social prescribing team. So really, really excited to have Justina on board with us. And Justina has pulled together today. Justina, do you want to introduce yourself and the session?
I think that after this introduction that you've made, I feel a little bit embarrassed. So maybe that's not the best option now. But I am indeed passionate about social prescribing, and I hope that this webinars, this peer learning that we prepare with Liana, will help us all to create a sense of community, so we can support each other and we can, advocate for development of social prescribing in each borough, each PCN, each surgery that we are supporting.
Justina pulls together the newsletter as well, and is going to be looking at a couple of other projects. I'm sure a number of you have spoken to her about the knowledge sheet that we're trying to create across London, so that we can start to see where specialisms in social prescribing are happening, and who's using which outcome measures, or how many link workers might be working across a PCN, or who people are employed by. So really looking forward to hopefully launching that soon, just as a prototype to get your feedback. So on the subject of growing teams, we have link workers are as the additional, some of you will know that your roles, probably most of you here today, your roles are funded by the additional roles reimbursement scheme through the DES contract, and that increases year on year. So the amount of money the PCN can draw down will increase year on year. As a result, PCNs should be looking to grow their teams, and because of the amazing work that you guys are all doing with your clients, increasing the referrals that are coming through, it's really important that we are able to justify growing those teams, both through sort of increases in referrals, but also through the positive impact that you're having in the work that you're doing. Some of you will be, actually I'll come to the outcome framework in a bit, but what we're going to cover today, we're going to look at a few different aspects. So we'll be looking at the coding. We'll have and an understanding of what social prescribing data should be collected, and the outcome measures. Many of you will know that PAM is no longer mandated by NHS, and it's not funded. The license isn't funded anymore. That's not to say that all areas won't be using it. I think North West London will continue to use PAMs, but we'll look at what outcome measures are required by NHS England and hear from some of the link workers around how they're using them and how they're getting the most out of them. Sort of how they're overcoming some of the challenges of using them. We'll think about, we're going to hear from some managers of services about what they do with some of their link workers. We'll hear from some services that are using different outcome measures that aren't mandated but are really beneficial to the work that link workers do, but also how we can talk about the impact, the positive impact that it's having, not just on the patient, but on the work of the surgery. Hopefully there's going to be lots of really useful resources referenced, and the resources will be circulated after the event in the slides. There's going to be lots and lots of opportunity for you guys to chat. So we'll be bringing you in, we'll be asking you questions as we go. If we could go to the next slide, please. So I'm curious, who of I think we've got a Zoom poll now. I don't know whether I can. I don't think I can. There we go. I'm curious to know who in the room is using outcome measure tools and questionnaires. I should say that managers. I suppose actually, yeah, managers can answer this question as well. I mean, that's good. That's great to see that 75% of you are. In the chat, those of you that are answering no, I'm really curious to understand more. Are you, if you're PCN employed, if you're part of a GP federation, if you're employed by a voluntary sector organisation, is anybody asking you to use these questionnaires? Curious to understand why the outcome measure tools are not as part of your work. You may be aware that all social prescribing link workers, I think, should be using the ONS as part of their work, as a baseline, along with the SNOMED codes, recording who you're working with. Let me just end that poll. Excuse me. Can we go to the next slide, please? So yeah, that's really interesting. So 77% of you. That's and what, if you could pop in the chat what outcome measures you're using. Really interested to hear what people in the room are using. I can't see the chat. Here we go. Okay, so some of you are in the PCNs. You're filling out monthly monitoring forms. That's great. I think, I mean, I'm guessing ONS. I have a feeling that message is out there. Keeping a spreadsheet, great. I get the sense there is a real conversation happening around around the wider tools, so things that can be used alongside ONS and we're going to hear from Dan Hopewell from Bromley Barbeau Centre about that. Let's go to the next slide. I think we've got. So I'll mention just quickly some of the things that I'm sure you're all aware of this already, and there's some really useful information there's a link there to the social prescribing summary guide, and there's also a PCN implementation guide, both of which have got some really useful information about data that could and should be collected. The Common Outcomes Framework is in Annex D of the first document that's featured. It's talking about measuring, the Common Outcomes Framework for social prescribing across the UK is looking at measuring the impact of social prescribing, and it talks about the person that you're working with, the impact on the community groups that you're working with, and the availability of their services, but also the impact on the health and care system. So how is it having a positive impact on the surgery that you're working with and the care system where people might be popping up. And obviously link workers can be taking referrals from anywhere. I think mostly across London what I'm hearing is that people are still mainly taking referrals from the GPs or practice staff. I think the other thing to mention here is that largely there is whilst a lot of this stuff is being collated, so SNOMED and ONS4 is being collated at a national level, there are conversations happening among some of the clinicians working on personalised care across London for a bit of a dashboard for social prescribing. So how can we collate specific data to make sure that we're talking about the impact of our work? One of the things that I think we keep coming back to is, how is social prescribing having a positive impact on health inequalities? How are we making sure that we are working with those that are most in need of the services that we're providing, specifically the sort of the social interventions. Lots of great chat. Please do get involved in the chat. So I think the next slide, please. Are we on to Martin now? Yeah, I'm going to hand over to Martin, who is the head of the evidence unit in the personalised care group at NHS England. Martin's been doing lots and lots of very exciting work around thinking about how we can talk about the impact of our work, but I'll let him talk about a couple of the projects I think that are specifically relevant to today's discussion. Over to you, Martin.
Great, thank you, Leanna. Can you hear me all right?
Yeah.
Yeah, okay, super. I'm promised to be really quick, and I have to go to another meeting in about 10 minutes anyway, so it'll be much less than that. I was just going to really follow on from what Leanna said, which is absolutely spot on, so I'm not going to repeat it all, but just tell you about a couple of things that we're actually doing that we hope in fact will make it a lot easier for you to do what Leanna just suggested. So we're working, the first thing to tell you about is that we're working on the idea of a minimum data set for social prescribing, which we're actually quite a long way down the road of, and Leanna and other people helped us test this idea out a few months ago, and we're hoping that it will all be in place sort of by Christmas. Always sounds it'll all be over by Christmas, like the pandemic was going to be, but there will actually be some changes which you will see in practice. I mean, basically that it really builds on what you're already doing. We already have a minimum data set, which is the 2 SNOMED codes for social prescribing referral and social prescribing declined, and also the request to use the ONS wellbeing measure, which, by the way, thanks to North West London, can be coded in health records. That's quite new, but you can actually put that into the clinical record. What we're going to do is expand on that, and I've got like one slide to show you which explains that a bit. We're just coming on to the reasons for doing it. There probably isn't time to kind of get a lot of feedback from you today. We've got a meeting about this tomorrow, which Leanna is invited to, and if anybody's really excited by the proposal, then tell us and we can send you the invite. But there's 3 reasons really. Firstly is actually for you as practitioners and the people you are supporting, really to kind of help you get that right, get that interaction right, to help you do your job well, and also make sure that the person understands what's going on, what's been recorded about them as well, and also on a practice level, so other people involved with the person, like GPs, actually know that you've done it, right? If we don't record things and make sure that people have access to some information, then it's all a bit invisible. The second really important reason is health inequalities, so that you locally, but also commissioners and us nationally, can see who we're reaching and who we're missing out. Now, we've got a report coming out from Oxford University probably on Monday, which does kind of show that we've made some great progress with social prescribing, but also throws up some questions really about whether we're really reaching the people who are most in need. So if we don't record things, we can't really know that, basically. And then finally, there's the one about results, knowing it is partly about outcomes, but also like what's people's experience and what support are they going on to take up. If we can't see that, then we don't kind of, again, know what's going on. So shall I just show the one slide? I think that's probably what we've got time for. I'll try, because Zoom doesn't work very well with our computers, so I'll just give it one go, because it means that you're going to need to stop sharing, if that's all right, Justina. I think it might work. Make sure there's nothing else in the way. So this is the kind of, basically, this is a very oversimplified, and apologies for this, sort of diagram which shows what goes on in social prescribing. And we know it's not a sausage machine, just to be clear, but this is just to help kind of get the concepts over. So it basically starts off with where the person turns up from, your initial conversations with them, what happens after that, and then kind of understanding, if you like, what outcomes or experience person have. So for each of those, there's a lot of detail underneath this, but just very high level, there's some specific data that we're suggesting not would always be collected, but which you potentially would be able to record. So the way to think about this is it's not like a kind of sort of demand for information from Martin or anybody else. It's basically you'll have access to a template, which some of you already do, whichever system you use, whether it's a local information system, which some schemes have, whether or not it's the health records. The template will just make it really easier for you to record the right information consistently. And there's 4 headings. The first one is actually crucially the health inequalities one, which is actually who I am, right? And what's my situation? So at the moment, I have to say that's pretty messy, is our understanding of what's in primary care records. Very badly coded. I mean, I think age and sex we get right. Sometimes we get postcode is out of date, or the person's literally, you know, we don't know where the person lives because they're actually got a kind of lifestyle which means they haven't got a settled place to live. But actually ethnicity is the kind of top one, really. If you were going to do one thing as a result of this session, I'd say maybe help people get coding of ethnicity right, providing the person's happy to kind of have that recorded, because it's really poor right across the NHS. Again, there's another report on that very recently. And then there's the other things that might be relevant. So we're going to have a set of categories about protected characteristics and other needs, including carers, by the way, who tend not to be recorded very well. Second one is kind of, well, what is actually, what matters to me is what we've called it. It's essentially already in there in terms of personalised care and support plans. It's what you might set your goals about, but what actually is the kind of basis of your conversation with the person, what actually was going on for them. They might have been referred because they've got a particular health condition, but that's maybe not the most important thing. So making it easy to record that. And we're using, because I'm going to keep this really short, not going to show you the detail, we're going to use something called the ONS well-being domain. So that's nothing to do with the measure, that's to do with the way, if you like, data in the public sector is aligned to what matters in people's lives. So housing, education, employment, family life, things like that. It's going to align, it's going to be whole life, basically. It's not going to be about healthcare, though health needs obviously come into it. The third one is kind of, well, what happened next? What actually, you know, you might have had a chat with a person, it might have been addressing some of those basic needs that they have straight away, in which case you could record that, or it might be they did go on to take up some kind of support, or you referred them on for another actual service. So what actually happened? And then finally, you know, how do we capture people's experience and actually try and measure outcomes, which I have to say is the trickiest bit, not for today. You need a whole session on why that's slightly tricky. But if we have that information, even, you know, very, very bare bones is all we're talking about, for a lot more people, then we would be able to understand at local level, practice level, and indeed, you know, commissioner and national as well, you know, who were actually reaching, what they needed, whether they got it or not, and actually, you know, frankly, whether anyone would come back for more of what we offer. And it also would help us argue the case for more of you, essentially, because people could see what a great job you're doing, but also, I think really importantly, more of the support that's actually perhaps currently lacking out there, particularly with the pandemic and the kind of funding pressures that have been on the voluntary sector. What is it that people actually needed? Was it advice services? Was it, you know, refugee support or whatever? That information kind of exists, but it's all buried at the moment, and this is we're trying to help improve. So I think I'll stop sharing because I did promise to keep it short and only do one slide. As I say, that is going to happen. Hopefully this will be in a sort of form that you can actually see and use very shortly. If you want to get involved, I mean, we can share the drafts, absolutely fine with that, if you'd like to see what we're up to. Finally, in North East London, they were going to do this anyway, so they've picked up the work we've done and kind of literally gone with it, and be very interested to get any feedback from people on the front line about how that's actually going. It might not have actually hit the ground yet, but the kind of, you know, proof of the pudding is very much in actually making these things work every day in your practice rather than them looking good on paper. So I'll stop there. 3 minutes to probably slightly over the 8 minutes. Back to you, Leanna.
That's great, thank you, Martin. We've got time for a quick question if there's any questions for Martin on that piece of work. I think the takeaway messages are that they use the first level is that they use the 2 SNOMED codes. The second level is that they're looking at some of the demographic information, and the third level is, so
ethnicity. Try and code ethnicity now if you can. Yeah, because it's really poor. Okay, 20% or more missing data, and I think it's just as bad in London as everywhere else in health records. Yeah.
Can I ask a question? A very quick
Of course, please do. Yeah.
So is this the work, and Leanna might be able to answer this. So in at the back end of last year, some information was circulated through the North Central London Strategic Social Prescribing Strategic Group about a piece of work being done to explore more SNOMED codes, blah blah blah. Is this that piece of work?
I would hope so, because what we've done is kind of lined ourselves up with our colleagues in North East London ICS, and their ambition was to kind of basically help everybody code into primary care records. That's what they've told me. They're only, I think, kind of getting going with it, but we're going to sort of see how that goes essentially over the next few months.
Right,
so it should be, and if it all sounds a bit strange, please come back and talk to us.
No, well, it looks absolutely superb. I did a screenshot. I know you're going to share this, but I work strategically on social prescribing as well as managing a service, and we've got a meeting in North Central London, and we've got a meeting on the 9th of August, and this will be just brilliant to be able to speak about this.
I misheard. It's North East London that we're more directly working with. So if there's anyone in North Central London we should talk to, then please just put them in touch with me. Yeah.
Helen, I wonder whether or not you should join that meeting tomorrow. I'll put you in touch with Martin after this meeting, if that's useful.
Thank you. Brilliant work.
Cool. Great. Thanks, Martin. Great, good to have you. I'll let you go because I know you've got
Thanks for the invite.
lots of places to be. Thanks so much. So Leanna's asked I'll just pose this question to the audience. How do you record referrals? And they've come to you from outside the GPs, that she's seeing people who don't consent to share with their GPs. So I want to put that question out to the audience. If anybody's got ideas, other link workers that are facing a similar problem, perhaps we can come back to that later. Let's move on to Michaela, who is, some of you will have seen some of the things that she's put in the newsletter. She's a link worker, a long-standing link worker down in Lambeth and Streatham, and part of the Age UK team. Is that right?
Yep.
Yeah. And many of you are using ONS4, and I definitely know that whilst you weren't fans of PAM, definitely ONS4 is a bit of a struggle when you're in certain situations, and given that it's the mandated tool, I think it's really important to share ideas about how we can tailor the use of ONS4 to use it to our advantage. So rather than me waffle on, I'm going to hand over to somebody that's an expert in this and is using it every day. So Michaela, over to you.
Pressure is on. The word expert comes in, and then the pressure. Hi everyone, I'm Michaela. So I'm the social prescribing link worker for Streatham PCN. My PCN consists of 7 practices, 54,000 patients. My initial appointments will be for 1 hour, and follow-ups will be 30 minutes via phone. In my initial appointment, I introduce the nature of my role to the patient and take time to explain their issues and the support they may require. I then use ONS4 and create a personalised care plan with targets for the patient. I tend to work with people up to 8 to 10 weeks, and patients have the opportunity to re-refer should they need the service again. So what is ONS4 and why do we use it? The ONS4 is the only outcome measure required by NHS England. Richter scale measures observable factors like employment, education, social life, health, physical activity, finances, housing, and looking at how the patient may feel about them. By evaluating the patient and using tools that ensure accurate details of their feeling and the impact of our service has had for them from beginning to end. Next slide, please. How do we do this? The first time I saw a Richter board in 2019, I wondered, how do we get a patient to do this evaluation? We all have our own unique ways of how we connect and build trust with our patients. What works for one of us might not work for another. Nevertheless, the majority of cases, we would be able to introduce ONS14 in a pleasant way with our patients' acceptance. I'll now demonstrate how I use ONS4 on Elemental using a test patient. Okay. So this is my test patient, Miss Yummy Dummy.
I don't know whether that's only for me, but I cannot see Michaela's screen.
Oh, one moment. Let's have a look. Is it sharing now?
Yes, we do see that. Thank you, Michaela.
Okay, just minimize this. So this is my patient. In my first appointment with Miss Dummy, who was referred to the service to gain access to services that can offer emotional or practical support. Miss Dummy explained she recently lost her job and is now a full-time carer for her father. She reports feeling overwhelmed with finances and struggling to pay her rent. She is not sure where to go for help and is currently living off her savings, which has caused her symptoms of anxiety to worsen. I've advised her that there are services that can offer her support, and I'm happy to refer or signpost her and support her over the next few weeks. In order to create a personalised care plan, there are ONS 4 questions I would need to go through with her in order to see her progress while we work towards her goals. So this is ONS 4. The personal wellbeing questions would be: overall, how satisfied are you with your life? The patient would then tell us on a scale of 1 to 10 how they feel. I do prefer ONS 4 to Richter, which I'll also demonstrate next. And that's because the Richter questions, sometimes for patients who are feeling really distressed, answering the Richter questions can sometimes make them feel not really happy to go through all these in an initial appointment. I will discuss those challenges next.
That's interesting, Michaela. So you would use ONS 4, but then maybe come to the Richter later on.
Yeah.
Nice.
And I think because of we all have our own ways of how we speak with our patients, but for me, I usually make sure that the patient feels comfortable, and the Richter questions sometimes don't feel as personal as the ONS 4 questions for me. And that's because we can discuss what the patient may be dealing with without the Richter's board questions, I found. Just get back to my main screen. Sorry, I'm just trying to get back into the actual meeting. Okay.
I often hear, Michaela, that people really struggle with when to know to use ONS 4. How would you normally use, when would you normally introduce, because some of those questions can be quite difficult to ask somebody and can be quite upsetting when they really think about the answer.
Definitely. So in my initial appointment, where we've got a longer time together, I let the patient express what's been happening in their life. And once I feel that I feel comfortable with answering some of those questions, I may ask for the ONS 4 in the first appointment. If not, then I book a follow-up appointment and go through the questions then. But I do let the patient know that it is key for me to do these questions in order to create the personalised care plan. And more often than not, that's really worked for me over the past 18 months. So that's usually how I do it.
That's interesting. So you would warn them, you're going to give them. I've definitely heard of link workers being asked to use ONS for questions with just some of the one-off calls they're making to people. And I would say that isn't really the appropriate time to be using it. This is about using it as a tool to develop a longer term relationship with your patient. And like you say, maybe you need to wait until there's some trust built there and give them a bit of warning that you're going to ask these questions, and for them to have a little think about how they want to answer them. And it's really important for them to understand and know progress themselves, be able to self-reflect and see the progress they're making, because sometimes that can be a really, really positive. That's a sort of an additional positive impact when you're working with a patient.
I would say for some, if a link workers dealing with a simple signposting referral, I wouldn't find it appropriate to do the ONS for. Definitely, I agree with you. I do feel that when you have a personalised care plan with shared decision making with the patient, that also helps them keep on track with the goals that they initially discussed in the first appointment. We all know with life sometimes something might come in between what your plans were, but if you have the original plan, it keeps you slightly more on track.
I've lost you. Where is it? Here we go. Do you want to move on to the next slide?
So did we cover the challenges for Richter scale? I think that's what we basically was just speaking about. Yeah. Okay, so why is it good to collate qualitative data for our PCNs? Personally, due to the fast-paced nature of our role, we are not always physically visible to our PCNs. For this reason in particular, I found that presenting case studies of patients that have met targets and made progress is key to promoting our amazing work. Not only does sharing case studies or good news stories share what you have achieved, it will also give a gentle reminder to the power of social prescribing and the impact it's made in the community and encourage new referrals. When to collate and what to do after. Collating via Elemental for me is upon discharge from the social prescribing service. I review the case notes and highlight the most relevant info and create a good news story. Like any traditional story, it has a beginning, middle, and end as follows. Why the patient was originally referred to me, how I've supported them, actions and targets achieved, and where I have referred the patient to. Finalising the outcome of the last appointment, I use ONS4 in our last appointment, give a result summary, sustainable changes for the patient's life. I then send a monthly keeping in touch email to our clinical directors, GP leads and practice managers to share the impact of the case study. Next slide.
Should we go to the next slide?
How using ONS4 helps me present quarterly reports. I've attached a copy, well, Justine's kindly attached a copy of my drafted report for my PCN. This covers either ONS4 or Richter scale demographics for patients that I've supported in that time period. The link there will take you to the future collaborations platform if you do want to have a look. And finally, my top tips. Practice using a tool with your peers and take turns being a difficult patient and review how you answer questions. 2, always be your authentic self. Although we remain professional at all times, patients notice when we're being textbook. Be mindful in how we speak to the individual. 3, create yourself a folder of case studies that you have prepared upon request, which saves you admin time. If in doubt or in need of training or support, always ask for help, whether it be with your PCN or an external organisation. There are pathways in place to support us. Thank you.
That's great. Anybody got any questions for Michaela? I'm going to, whilst you think of any questions, I'm going to bring Kerry in. You've got a lovely tip there. Do you want to share it with everybody?
Yeah, it was just when you asked in the chat about any other tips and what Michaela was saying about rephrasing the question and kind of personalising it to the individual, which is so important. What we also find helpful for some of our clients is not just rephrasing the question, but rephrasing the scale as well. So if the scale was completely, mostly, a little, and the client finds that hard to kind of understand, or it's not how they would kind of indicate, we can use different options. So we might be like, how much, like that much, and using hands to indicate, or like percentages or numbers or something instead of words, if that's easier. And we can just kind of mix it up a little bit like that.
Great.
Yeah, I agree.
I've got a feeling that there's I mean, everybody's using ONS4 at the moment, and there's probably a lot of the questions I tend to get are around how to code it in EMIS. And what I would say is, if you feel like there are opportunities for you to be using your tech better, feed this stuff back to your PCNs. and any progress that's being made in various bits of London. So for example, in North West London, on the templates they're using, we can share news about that in the newsletter. Thank you, Michaela, that was brilliant. Thank you so much. We're going to move, we're running a little bit behind, but I'm going to introduce Dan. I think we've probably got time to not worry too much. Many of you will know Dan as the London Regional Facilitator for Social Prescribing. He's been around for a really long time on the scene of social prescribing. He knows, if he doesn't know about it, it's probably not worth knowing about. Is that the saying? But he also teaches on the level 3 social prescribing accredited course, and sits at the Bromley by Bow Centre, who are kind of long-term innovators of, well, pioneers of originally and more recently innovators of social prescribing. So I'm going to hand over to Dan to talk a little bit more about kind of past ONS4, the different, you know, other outcome measures, and the one that Bromley by Bow use and why it's useful.
Great, thank you, Leanna. Can you hear me?
Yeah, perfect. Great,
thank you. Yeah, I think this is really interesting to explore. You know, we've had PAMs, and PAMs have sort of come and gone. We've got ONS4 now, which I think has got a much higher level of acceptance amongst social prescribing link workers than certainly PAMs used to have, which people found quite clunky to use with clients. But it's worth thinking about. There is a plethora of other tools, some of which are validated, and validated means that they've been used in multiple settings, not just social prescribing, but lots of other things, and essentially produce the same kind of scores with clients who've had the same improvements in their lives in multiple settings. And therefore, the score movements in a validated tool are considered to be reliable and robust, and to have kind of generalizable, you know, you compare, I don't know, an employability project with a social prescribing scheme and say, you know, if they both shift well-being, then you feel you've got a sense of belief in the judgment that they both work in a similar way, kind of thing, or generate a similar result. But so what are the range of tools? Well, there's a whole plethora of different tools. Some of them, such as, for example, well-being stars is one. Warwick Edinburgh, which was very much in vogue a few years back, both the short and the long Warwick Edinburgh scale. There's EQ5 as well. But the one I was going to talk about today is one called MyCore, and it's now hosted by a charity called Meaningful Measures, and it's free to use, but you do have to tell them that you're going to use it. That's the only thing, and they'd be delighted if you can feed back anonymized results. But it's absolutely free to use, and there's no obligation to feedback results. MyCore asks 3 very, very simple questions, and I think one of the advantages of MyCore, which is my well-being and my concerns and well-being, is what the initials stand for MyCore, is that it serves as a planning tool as well. And I think one of the challenges for any outcomes measure that link workers use with their clients is that one has to be careful that the use of the tool with the client doesn't in some way deteriorate the quality of the relationship and the rapport that the link worker is busy trying to generate with their client. And in a sense, you know, this feeling of kind of being measured by somebody else, in this case by the link worker, you know, can have that effect of people feeling that they're kind of, you know, a bit like a laboratory animal in a sense, and that, you know, that, and obviously, so one needs to have good introductions for using tools and explain to clients why one's using them, why it's helpful both to you and to the client. MyCore asks 3 very simple questions. The first one is, is there anything that's concerning you? What is your main concern? And on a scale of 0 to 6, how bothersome is it? 0 being not at all bothersome, and 6 being incredibly bothersome. And you ask that twice over. So you basically ascertain from the client the 2 issues, the 2 challenges or concerns that they've got that are most concerning them and how much they are each concerning them. And this really serves as a great prompt then to discuss with the client, you know, are either of these two things the things that you would like us to work on as a link worker with you to help you to improve these things. And then, of course, as a follow-up, a few weeks later or months later, when you've finished working with the client or towards the end of that journey, where you again ask the same questions, and you hope that things have shifted and become either resolved completely or less bothersome to the client. The third question is around well-being, and it just asks them to rate how their general feeling of well-being is, or how do they feel about themselves. And again, it's on a scale of 0 being as good as it could possibly be, I'm feeling as good about myself, or I'm feeling as good as I possibly could imagine I could feel, to 6, which is as bad as it could possibly get. So again, one would hope that that score shifts in the follow-up score as well. I'm going to talk about something else very briefly that we do at Bromley by Bow, or we have done in the past. And I think, you know, validated tools are fantastic, but we need to go beyond those as well. We've already had a fantastic example of a case study. One of the things we've done at Bromley by Bow is to ask, to carry out a survey with clinicians in our primary care network. And this produces a pretty high level of responses. About a quarter of the people in those primary care practices respond to this questionnaire. And it asks them some very, very simple questions of the GPs, nurses, healthcare assistants, reception teams, and practice managers. And it asks them, do they believe that social prescribing brings well-being to their patients? And the scores we get are usually around about sort of 95% saying yes. Do they believe that social prescribing brings well-being to them as professionals? So having the access to social prescribing, is that beneficial to them as professionals? And again, a similar score. In fact, this was even higher, 98% thought that social prescribing and having access to refer their patients to social prescribing was good for them. The really interesting questions, 2 more that we asked them, are if we withdrew the social prescribing scheme, what would they try and do? And 55% said that they thought they would try and find services themselves, but that they thought they would be inadequately trained to understand what the services were that might be available. And many of them doubted that they would have the time to actually spend, you know, going on the internet and trying to find out the services, and then probably having to print something out for the patient to get there themselves. So you know, but the even more interesting one, I think, is we asked them, if we did withdraw the social prescribing scheme, also what would happen to your consultations? And 35% of them said that they would deliberately steer away from having a holistic consultation with their patients, because if they did and the patient revealed a social need, if they didn't have a link worker to refer to, then what on earth would they do with that information? So they would deliberately avoid asking their patients about the other things going on in their lives. And we thought that was really telling, actually. So I would, and that questionnaire is on our website. You can check it out. We can send you the link to that. You can copy it or amend it. But we think it is a really good idea to ask your professionals, the clinicians who are making the referrals and the practice staff, what do they think of social prescribing, and to give their opinion. And that's very, very powerful. And we then feed that back to them and tell them, you know, do you realize that 98% of you said that you thought social prescribing was good for you as a healthcare professional? You know, that's very powerful stuff. That's feeding their own opinions back to themselves, as it were. Okay, Liana, is that good for now?
That's great, Dan. I was just thinking that really, not only is it a great segue to the next speaker, but it's also, I think it fits directly with the Common Outcomes framework. The NHS, I'm going to put a link to the document and guide you towards Annex D, just to give you an outline of the sorts of things that you should be collecting as a link worker or as a manager of a link worker service. Are there any questions for Dan before we move on to the next speaker? How can we get Michael on Elemental? Is that something that you know anything about, Dan? I'm guessing, I know that definitely there's been piece of work around NHS England have been working with some of the digital providers to let them know what they want from their platforms, and Justine has been feeding into that. And I know that Martin Cattermole didn't mention it today, but it's certainly something that they're interested in. If you've got suggestions for how the digital platforms could be better used, and this sounds like a very obvious one, we can certainly feed that back to them. Have you got any, did you have any thoughts on Elemental, Dan?
I would have thought that would be, I actually thought it was on Elemental, and I'm just Googling this now as we speak, and it seems to be mentioned on the Elemental website that it will accommodate MyCore. But I will check that and come back to you in a few minutes if you like, Leanna.
Right. Pop it in the chat.
Yeah, okay, well done, yeah.
Fab. And we'll dig out the survey as well and pop that in the chat, but it'll also come in the resources when we send on the slides. Thanks so much, Dan.
Leanna, there's a tweet from Elemental saying that they're delighted to be working in partnership with MyCore and working out how to get it onto Elemental. So yeah.
Fab.
Yeah.
And I think more and more we'll see this happening, especially if it's things that link workers are using. I think probably with the ditching of PAM and the advent of a broader range of outcome measures, more and more of this, we'll see more and more of this developing. Thanks, Dan. Next speaker, we've got Barnet have been doing some really good work around using data. So I'd love to introduce Louise, who is part of one of the link workers in the Barnet service. I'll let you introduce yourself, Louise. Are you there?
I am. Hello, thank you. Just before I start, I was asked by the social prescribing manager of our little group over there to step in. So if there are any questions, if I can't answer, I'll find out the answers for you. So within the PCN I work in, there are 3 social prescribers, and between us we cover 7 surgeries. The sessions that we carry out, they can last 10 minutes. Sometimes it can be anything from the number of the blue badge department at the council to over 30 minutes. If it is a 10-minute call, we obviously ask them if they need any more help, if they need any assistance with anything. And if not, then that's kind of that. And we discuss what they've been referred for. So what do we measure and why? So we use Elemental, like a lot of people, and we receive referrals on Elemental from GPs and other surgery staff. We make notes of the conversations we have with the patients, and we record the social prescription and the ONS4 and the GP visits in the first session. And then once that's done, once we have finished with the patient and discharged them, we record it again to see if the GP visits have come down. We also use a feedback survey, which is sent out to all the patients that we've discharged. We send that via email. That comes back, and then we discuss how we can improve, and our SP manager feeds back as well to the certain link worker about good feedback. So how do we do it? We do this by using Elemental and inputting the data that is then pulled by the social prescribing manager every month. And by using Elemental, it helps us to keep a record of how well social prescribing works with the surgeries who we support. It helps us to see if social prescribing is working for the patients who are referred to us, and record the data once we have discharged them to find out if the patient isn't going to see the GP as much as they were before being referred to the SP service. Okay, next slide, please. Thanks. So in our annual reports, we include information related to overall summary, referral totals, that's per month and its PCN split, referral by GP practice, age and gender of total referrals made, appointment types and number of appointments made by a PCN, contact times of appointments made, most common referral reasons for the service identified, most common signposting and referrals made by social prescribers, the percentage of referrals made for each referral reason to the service, the outcome data of the ONS and GP attendance records, and feedback survey results. And as you can see from this slide, it illustrates how we report GP attendance, hospital admission and A&E admissions. And the report is presented to the PCN on a regular basis.
That's super compelling data. Just if we could just hold on that slide for a second. I mean, obviously this is something that your manager is pulling together, Louise.
Yes, she is.
When you're getting to the end of the month and you've got the benefit that you've got one service that's happening across the whole of the borough, you've got a pretty big team of social prescribers, and there's a lot of investment. I think there's collective investment, isn't there, from the local authority to understand where unmet need is, as well as the health side of things to understand the positive impact it's having on health. So there's some really great reports coming out of Barnet, which I'm sure Caitlin would be happy to share with any of the other managers or link workers.
Oh, absolutely. Yep.
How does this impact your work as a link worker? I mean, I think this is, I'm going to sort of anticipate that this is really helpful to get your foot in the door and be able to use some of this data to tell GPs the value of the work you're doing.
Yeah, we're quite lucky in our respect, especially in the PCN I work in. I'm really lucky that the surgeries that we cover, they're just completely on board with it. We've got a fantastic clinical director who is all for it. And we speak with one of the GPs that kind of heads up social prescribing for that PCN. And she asks us every week how our referrals are going. And if we sort of say, yeah, you know, this week's a bit quiet, which it is, you know, we all know that some of our weeks are quieter than others. And then she'll send out a message on WhatsApp to all the GPs in the PCN and go, could you, you know, referrals, don't forget that the girls are there ready. So then you get an influx. But we're really supported, and this just reflects it. This just reflects that what we do works. So it's very helpful to have this. And I think Caitlin filters this back to the PCN. I think it could be every couple of months that she filters this back.
Yeah, and I guess it might have the dual benefit of informing who they might be sending to you.
Yes.
And this is the whole reason. I mean, I feel like a bit of a broken record sometimes, but trying to reinforce the message. It's so important that link workers have time with their patients, because if you have, you know, you can see here that the reason people keep coming back is because nobody to the GP service is because nobody's really getting under the skin of the wider issues and the things that are having a real impact in people's lives, and link workers need time to be able to do that. And I think if link workers are given the time, it will really reflect positively in these figures. Yeah,
I mean that's one thing that I personally definitely hear when you phone up a patient to do the initial, like, booking in an appointment with them via the phone, because I'm not in surgeries at the moment, and when you say to people, you know, the first consultation, it can last sort of 20 to 30 minutes, like that long. It's like, well, you don't have to, you know, you don't have to use all that time. And they're just sort of, oh, well, the doctor only gives me 5 minutes. I'm like, yep, you know, they have like 5 to 10 minutes. We're lucky enough to have a bit longer. So you do, like you say, you do get under the skin, and you do get to the root sometimes of the issue. So it's definitely so beneficial to have not a time limit, but more time than the doctor has. We're very lucky in that respect.
Yeah, definitely. Are there any questions for Louise before we move on? Thank you so much, Louise. That was super helpful. We'll be circulating this afterwards. I think there's lots of gays asking whether or not who would be good speakers to come along and talk about the outcome measures. To be honest, Gay, I don't know the answer to that. It might be that you can find some useful YouTube clips. Definitely, please share this recording. Maybe it's something we could look to a short video we could look to create with just populated purely by link workers. We'll see in a bit that Justina's mocked up a really lovely map to show who's using what across London. Can we go to the next slide, please? I think we're going to hear from Caitlin Swan now. I'll let Caitlin introduce herself, but essentially one of the things that we are, data is really important, but actually telling a story is the thing that can sort of change hearts and minds sometimes. And one of the things I know that link workers, one of the big challenges for social prescribers right now is getting people to understand the complexity of the cases you guys are dealing with, and that you aren't just referring people onto yoga classes and gardening groups, and that actually there's lots of really complex social issues that are being tackled in the work that you're doing. And you know, obviously sharing the importance of this work in stories is very important. So I'll hand over to Caitlin to talk about some of the stuff they're doing in her patch.
Okay. Hi, Kathleen Swan. I'm managing the care navigation and social prescribing team at Age UK Camden. And I put the care navigators there as well because we're working as a team, care navigators and social prescribing link workers at Camden. And also we're affiliated with the Voluntary Action Camden as well. And they've got their volunteers and admin as well who support us with social prescribing in Camden. So I just outlined here on this slide just the difference in role between the care navigators and the link workers. What we're trying to do is not to duplicate work, but to work together and collaboratively, navigators and link workers, and we refer between each other as well. At times we work together on one particular patient which might need you know, longer work, or they are more complex, then maybe care navigator takes them if they are more complex and they need more like housing support, finances and those type of things. However, with the link workers, we're trying to emphasize more the social prescribing type of role, so social isolation, improving health and well-being, running peer support groups, which PCNs are really keen on. We're currently developing a walking group, which is going to be hopefully good for us. We receive a lot of referrals for mental health needs patients. I'm sure that's the same for most of the link workers as well. So that's just a quick overview, and then I'm going to talk about a little bit more of the outcome measures. So the next slide, please. Okay, so we are doing two different type of things. Somebody was then, I think, was talking about MyCo earlier. So we do use MyCo as well. I don't know whether I have included those questions here. I've got a sneaky feeling I might not have, but nevertheless, we've got the 5 MyCo questions which we use. Now we've got we use charity log mainly to record data, and we embedded MyCo into charity log. So when the link worker goes into charity log to record everything what happened, the sessions and all the personal information and everything of the client, then they are reminded to complete the MyCo form as well, when they start with the patient or the client, and then they finish as well. So that involves 5 questions. On top of that, we also have these questions which are listed here. We've got an admin and 2 admin volunteers who support us with collecting this feedback information from patients. We're aiming to complete around 15–20% of patients per month to actually get referral feedback from. So as I say, the admin volunteers call the clients and ask these questions. It's not prescriptive, so they don't actually have to ask exactly the same questions the same way. More of having a conversation with the client and find out how their journey with the link worker and with the care navigator went, and what were the outcomes, if they felt supported, if they felt that the solution was found to their problems, and the rapport they might have had with the link worker as well. And then we record this in SurveyMonkey. And we have the record of the name of the link worker, who the feedback is for, and the percentage of yes and no answers to these questions. Now, normally I would say to that, I didn't put the percentage here, but we've got really high percentage, so it's between 90 and 100% always. Of course, sometimes we come across people who are not completely happy, but it's to do mostly with their health condition, or maybe the problem is not solvable quickly, or something like that. But overall, we have a good result and good feedback. Now, we share this feedback with the PCNs quarterly. And I also report on the qualitative data we collect as well with the PCN, so number of referrals received, ethnicity data, which surgery sent the most number of referrals in each month, and cases managed each month. So it's quite comprehensive. I'm happy to share that as well later on, maybe, and we can send it out. So we have another feedback as well, which we created. We wanted to know how GPs and an NHS basically would benefit from the link workers' work. So let me just, because I can't actually see it, I just moved this over here. Okay, so we asked these questions, as you can see here, and the percentage, I think, speaks for itself. So the first question was, did using our service save you from attending one or more GP appointments? And almost 60.5% of people said, well, yes, actually, because you helped me, I don't need to go to the GP. I don't need to call the GP. I don't need to call the surgery reception secretary. So that number was 70.5% calling the GP practice receptionists, secretaries. That much time was actually saved. And the final question was, if you had not used our service, where would you have gone for help? And 66.38% said, well, I would have gone back to the GP. I would have asked for help there. Some of them said they would actually call the council. And others said, well, they would have just turned to other voluntary organizations, charities for support. And there was 11% roughly who said, well, actually, they would have no clue where to go at all. So I think that is just a demonstration of the strengths of this role and what we actually bring to the NHS as well. Yes, any questions on that at all?
No, that's great. Were you going to talk about the case study examples as well?
Yeah, so the case study is next.
Minutes. I'm just conscious that we've hugely run over, but I think this is useful to go into this stuff in detail. But
okay, I will speed up. Okay, so yes, case studies. So we collect case studies. I ask for 2 to 4 case studies per month. So it's not to overwhelm the link workers, because it does take time to actually write these case studies up. So they look good and they are presentable. And this is just an example of a case study here. The form, you can see the form next to it. I think you can click on it and then it will just give you the blank form. But we do collect, as you can see, who the client was referred by, age, gender, ethnicity, sexual orientation. So we've got the general idea of the client's background and who they are, and then the reason and actual finding. Now we put actual finding in there because sometimes what happens, there is a reason for referral, and when we do the assessment, we find out that actually the client wants something completely different. So that's why we include that. So that was the referral reason, but when we went in and talked to the client, that's what the client actually wanted. And then we include the actions, what we propose to do, and the referrals we're going to make. So if you just see the next slide, then that's the end of the form. And what the link worker, how did she or he actually followed up with action? So as you can see here, the link worker was really busy and done really a lot for this particular client. And finally, it's important to include the outcome for the client. So we clearly see just a clear summary of how did the client benefit from this service and what they have achieved as well. So I think it's a very good structure just to show from beginning to end of that journey, of the client's journey with the link worker. And then we submit these forms, these case study forms, to the PCN quarterly when I do their reporting. So they have, you know, a number of case studies for them to read through and also put into their reports if they wish to do that as well.
Great, thank you so much. Are there any questions for Kathleen before we move on? I think there's some of the resources that you've created there. We'll definitely be sharing in the newsletter. I think there's a wider bank of social prescribing link workers I think would find this stuff really, really useful. And I think having a template for writing a case study is just makes things easy for people. So thanks so much, Kathleen.
Sorry.
Oh yeah.
I just have a question regarding the follow-ups that the link worker done. So was the link worker the one who care coordinated the follow-ups for the hospital appointments for the patient, making sure they got the x-ray, or was that the care navigator?
No, link worker.
Okay.
This was the link worker's case study here.
All right, thank you.
It's a good question though, Michaela, because I think obviously in more and more systems, there will be care coordinators coming into the service, and it's possible that those tasks would be taken on by the care coordinator, and that's definitely to be decided in the local systems. And I think the care navigator and the care coordinator are not necessarily the same role. I think, or at least care coordinators are going to be used potentially very differently in each PCN. And I would say to anybody that's wanting to understand a bit more about the 3 different roles and how they might work together, we've got a session happening tomorrow that will be, it's largely directed at primary care networks and practitioners to a certain extent, about how to use these roles effectively. So what would be how do we make sure that these roles are being used in such a way that's going to have a really positive impact both on the patient, the voluntary sector organisations that are based out in the community, and the health service that they're sat within. I will pop a link for that event in the chat. I'm going to move, Kathleen, thank you so much for sharing with us. I'm going to move you on to the last speaker, which is Kerry. Kerry's going to talk us through Leaf 7 and presenting sort of like the patient's feedbacks and presenting reports to stakeholders. We haven't got loads of time, Kerry, so if you pick the bits that you think are new, any top tips that you think are useful, but any bits that are new, that'd be great. Sorry, that's my poor chairing, I'm afraid.
Okay, that's absolutely fine. So I'll just focus on Leaf 7 because I think for most people that's probably quite a new thing. So we're commissioned by the PCNs but employed by Age UK Sutton. So Age UK Sutton have another service that supports hospital discharge, and they use this wellbeing monitoring tool called Leaf 7. So it was originally designed by Age UK Wakefield with support from some of the universities up there to develop it. And that worked really well for that service. So when they received the commission for social prescribing, they thought it was a really good fit. And we prefer to use Leaf 7 as opposed to PAM, which was one of the ones, sorry, just getting distracted by the slides there, which was one of the ones suggested to us originally. So sorry, whoever's managing the slides, I'm just going to be talking rather than following kind of the points and whatnot, but I'll say to kind of move across. So if we move to the next slide, so just seeing the question there. So, and I will talk about Leaf 7. I think there's a slide that kind of just has the areas on there. If it's possible to move it across.
Can we go to the next slide, Berenice?
Okay, I'll just
Terry, maybe you could share your slides, because I think that that's it.
Perfect, thank you so much. So I won't show the whole thing because it's a license that you need to purchase, but I can give you a kind of summary of what it is. So Leaf 7 is very much a sort of holistic tool that looks at all the different areas of life and their scaling questions. And it's very much about the client kind of identifying how they feel about these different areas. So you can see there you've got around managing your sort of day-to-day living, managing your health, feeling safe and secure, which is really about sort of home environment as well as kind of what surrounds them. Doing what you enjoy as well as doing what's important to you and what you value, social contact, and being able to live life the way you choose. So understandably in the past year, some of these results haven't been as high as we'd like because of everyone being in lockdown and shielding, etc., etc. But what has been great is that we've seen improvement across all these areas within our first year. So we're just entering our second year now. So it's really helpful using these because as well as helping to facilitate that discussion as part of the assessment, it's really helpful for the client as well as the link worker to sort of think, right, well, what are the lowest scoring areas? What should we focus on? And that really helps around goal setting and around prioritizing, because quite often, as I'm sure across the board, a patient, a client will come to you and will just, you as a link worker might be the first person that they speak to about all these different things because they've got the time to do that. And you'll hear lots of detail, lots of things going on. And these questions really help to kind of narrow down into focus into what might be the priorities. If we just go to the next slide, if possible. Sorry, I'm being annoying, aren't I? Asking you to move around, thanks. So these form part of our assessment tool, which is our Pcat, person-centered assessment tool. So as well as these Leaf 7 questions and the ONS 4, there are various other questions around sort of demographics and other optional questions which we can do if the patient, the client identifies that these are areas they'd like to focus on, so around finances and housing and things like that as well, benefits, etc. And the results from this form part of the report. So I report monthly internally during the sort of monitoring meetings, as well as to our steering group, which is made up of primary care, representatives from the voluntary sector, the council and so on. And I also provide that information to our PCNs. So we've got 4 PCNs in Sutton, and we've got a team of 6 link workers that work across those 4 PCNs doing that. And then quarterly, there's a qualitative report, which is the written report, which kind of gives a bit more information and detail around sort of the KPIs and the numbers, because as well as reporting on the data, we really want to explain what that means. So helping us to really identify some of the trends, as well as some of the gaps as well, and reflecting on what's kind of going on within the sort of wider society. So for example, COVID and the lockdowns and the sort of impact that that's had. And then every end of financial year, I'll make a sort of bigger report, and we can share that with anyone that's interested, really, as well as sort of our steering group, our commissioners, etc., and other stakeholders. So I will finish there. That was really quick, but hopefully that will be helpful. Within the slides, there is a link, so if you'd like to find out more about Leave 7, and if you've got any questions at all, obviously do feel free to ask me now or ping me an email across.
That's great. Are there any questions for Kerry? I think what's interesting, just to reflect on what's happening, that everybody across London is doing something a little bit different. I think, and for the link workers that are based in the PCNs on their own, I'm really hoping that by sort of convening these types of meetings, you can benefit from some of the resources that are being created where there's perhaps a bit more capacity in other boroughs. Please feel free to pop any questions. We've got a few minutes left, so any questions that are coming through, then chuck them in there. Can we go to the next slide? I think it's really, is the next slide the one about the, yes, so this is illustrating what's being used across London. Now, obviously, let's assume that everybody's using ONS4. Let's hope that there are still some people that are using PAM, and we know that in Northwest London this is something they've bought the license for it and are probably going to continue using PAM. I think one of the things that we're hoping with this map is that you'll be able to connect with each other. You'll be able to identify people in other bits of London that are doing something similar or are using something you're considering, and be able to reach out to them and say, you know, how is it going for you? How are you using it? How are you recording stuff on EMIS? I feel like a lot of questions are coming through myself, and to be honest, it makes sense that you're asking each other these questions. And so we're just trying to think through how we can really galvanise the London network so that you can be reaching out to each other to be asking each other these questions. Can you go to the next slide? I'm conscious that there's quite a lot of there's a lot of Justina's pulled together an amazing toolkit page and an outcome measures database. So we can share all of this stuff. Gay, this might be the thing to share with your team if you're trying to get them to think about the broader well-being and outcome measurements or tools that you can be using. This might be a really good place to start. Next slide, please. And there'll be, excuse me, there'll be some ways in which you can be upskilling yourselves around how to do, perhaps those of you that don't have a manager or feel that you want to do some of this EMIS reporting yourself. There are definitely some recordings online that can walk you through how to extract some of this data on EMIS or System 1 in order that you can start to talk about the kinds of people that you're working with. And as the evolution of the SNOMED code comes about, there'll be all sorts of things that you can be reporting to your PCNs. And it's worth saying at this point that there are lots of SNOMED codes there. There are 2 that are mandated to be used for all link workers, but there are lots of other SNOMED codes, and I know link workers that are using additional SNOMED codes just in order that they can start to gather some data about the needs of the clients that are coming to them and some of the services that they're referring them on to. This is also worth noting, best practice indicates it's advised you speak to your line manager before running these searches. And I think in lots of cases, especially where you don't have loads of capacity, perhaps speaking to a practice manager or somebody that's really passionate about social prescribing within your practice, and getting them on board with this as well, could be really useful. Next slide, please. Another great tool to evaluate your outcome measures, to understand and think about what it is that you're, make a bit of a plan for yourself about what you're going to collate. Again, this will be shared. And anybody that's got some really good resources that we haven't got here, that I think there's another resource page, if you go to the next slide, please, share them with us, and we can put them in the newsletter. We can, let us know what these sessions should be, any resources you're using that we could be sharing with other link workers. We've got a couple of minutes. Justina, do you want to come in?
Yeah, just one thing. I set up resources like Social Prescribing London toolkit. So feel free to add to this database. So not necessarily you have to, contact us on all of these occasions. You can freely co-produce this database. You can add your documents or templates, so all of us, we could see and share. So that's just one thing that I wanted to add.
No, and it's really important, because to be honest, what we're trying to do at the moment is think about the sustainability of this sort of network and this support. And it's possible that it's not going to be around forever, and thinking about how we can hand some of this over to the system, so we can create some sustainable platforms for you guys to be sort of continuing connecting with each other. Can we go to the next slide? I don't think we've got enough time for discussion, unfortunately. Are there any comments from the room about this session and how these sessions work? Possible ideas for next sessions? Feel free to shout out. Have we sent you all to sleep? I hope not. Hopefully you've all got a sandwich in your mouth, and that's why you're quiet.
It's been really, really helpful. I think I've put in the comments, very, very good session. So yeah, no, I mean, these sessions are very good, and I have to give complete credit to you for your newsletter. I think your newsletter is excellent. The management of social prescribing, I'm a social prescribing manager and sit strategically on the ICP, Integrated Care Partnership Board, yeah. And what you're doing, Leanna and Justina and your team, it might just be the two of you, is excellent and really, really, really helpful. Really helpful.
I have to say, it's a bit like, but bringing Justina into the team, we can't do this stuff without you guys. And I think the most important thing is, if you can be making us aware of where there are pockets of best practice and innovation, our job is really to sort of try and create that spider network across London, so you guys can be connecting with each other, and we can be looking at some of the active ingredients that's making some of these things work really well. I mean, this was not a training session or a comprehensive session. It's what we really try to do is create a bit of a platform for some voices that are doing some things so that other people can hear and get some discussion going. One thing we haven't really nailed yet is how we can get people talking outside of these sessions. We've tried the platform, which we've tried Teams channels, and I think if anybody, this is a call out there for anybody that has some ideas about how people can be connecting. We're going to be sharing the knowledge sheet soon. That could be a good way for people to be emailing each other, but it's not really, there's not going to be public chat necessarily there. Any ideas for future sessions, ways we can be connecting across London, what you think is needed consistently, for everybody that we can be doing once for London, please get in contact with myself and Justina.
One short-term solution possibly could be like a closed WhatsApp group for those involved with the social prescribing and build up of it. Long term, I thought of making an app for the social prescribing service, so link workers, managers, and everyone can come together. And those of other link workers who haven't been able to attend these kind of useful sessions might be able to find out about them via the app. But again, that's a long-term idea that I had. But
Michaela, I think you share the aspirations of many of us. I know Justina in the room has definitely been interested in thinking about coding. I've reached out to an organisation recently who train up individuals that are based in a war zone, actually, and so they will take on a challenge and try and come up with a tech solution. So maybe there's something around, and we've talked to them about this very thing, you know, creating an app or creating some kind of a platform where people can connect. And we've got a website and an apps developer in the room as well. This is fantastic. Right, okay, I think we've got a working group here. We will, once we've got a couple of pretty full-on weeks, but once we're out of the woods on for the next couple of weeks, I think this is an action we need to sort this out. Let's do it. Really, really, really lovely to see you all. We will be in touch with some of the things that have been discussed today, and obviously share all the resources. If you're not receiving the newsletter, get in touch. Make sure your colleagues and friends are receiving it as well. It's going through to lots of people's junk. So, and actually get in touch with us if you've got ideas of things you want to include. Great to see you all. Take care, guys.